All right, hemophilia, we spoke a little bit about this last week. It's a group of hereditary bleeding disorders. The most common is factor VIII. And in this type, classic hemophilia is mostly entirely a male. Most of the hemophilia disorders are male because they're X-linked recessive, which we spoke about. So it's not that they don't bleed. It's not that they bleed faster or greater. They just bleed for a longer period of time. Okay, because a clotting factor or multiple clotting factors are usually missing. So it's not that they don't have platelets, it's not that they're just missing clotting factors. They can actually give them the clotting factors if they know they're going to have surgery. So it's not to say, because years ago we say, oh, people with hemophilia really can't have surgery. No, they can actually give blood transfusions, they give packed platelets, they actually can give more of the clotting factors if there are issues with, if there are issues that they're concerned about bleeding. It's the trauma that people don't know what to do with. So for example, you know, they could bang their knee, and then they end up, you know, with something like that, hemiarthrosis, or bleeding into the joint. Bless you. So these are the kind of things, you know, so it's the unexpected traumas that cause a problem. So again, prolonged bleeding from anywhere in any form of the body. So where do you think is the first thing that might lead to a diagnosis of this? Like how early or at what point might they have a diagnosis? What were you going to say?
When they cut the umbilical cord.
Very good. Pascal said that when they cut the umbilical cord, they can have prolonged bleeding at the umbilical stump. What else?
Circumcision.
That's right, Stephanie, that's the other point. Circumcision. Oh, is it? Yeah.
Pascal and I are just
Yeah, I
really
was
smart.
wow, I'm really impressed.
No, I mean,
I should have went one
Oh,
more
she saw
back.
I saw it, like, she actually knew it.
Oh, then I'm impressed, Pascal. So again, you know, these are the things we're going to think about. And it's the trauma that causes them a problem. Obviously, you want to make sure that they apply pressure, and then they're going to need blood transfusions. There was somebody named Brian White years ago, I want to say in the 80s. I mean, I remember it distinctly. But yeah, and he was the first, I was going to say, he was really the face of AIDS in somebody who, you know, did not get it from like drug use or sexual contact. He actually got it from multiple blood transfusions because back then they weren't tested for HIV or AIDS. And he ended up dying, but he had hemophilia. So they get multiple blood transfusions. And actually now they can replace clotting factors, which back then they didn't. So that also does help.
Is that why they got the blood transfusions?
Because they would have so much, like they would have something happen and they would be bleeding, and they would need to replace the blood.
So it would be after something happened?
Or during, or even preventative if they knew, you know. But some would go in just like with sickle cell every couple of weeks. Most of those patients, though, were getting blood transfusions. Now they don't do it as much because, again, they have to replace the clotting factors that are missing. But some of those people were just going in every, you know, every couple of months or weeks, you know, needing to have blood transfusions. And that's why they were ending up at risk for that. So again, the diagnosed history of bleeding, X-linked, so genetic studies, and then lab findings, the PT and PTT. So somebody has said to me in the past, well, if the PT and PTT are so elevated, why don't you just give vitamin K? That's right, because it has to do with the clotting factors. Although you can see elevated PT and PTTs, it does not, vitamin K would not help. It has to do with the clotting factors themselves, you're right, that are missing it due to this genetic abnormality. And it is lifelong too. So you want to prevent the spontaneous bleeds and minimize bleeds when they occur, replace the missing factor, and prevention of complication bleeds. What I can say that we do really well now is replace the missing factor. We do have synthetic versions of most of the missing factors, especially the classic type. So with replacement of the factor, they're less likely to bleed so long anymore.
So do they advise parents to have the child avoid pretty much any sports and stuff
Strenuous
like that?
sports and activities, absolutely, anything that might cause them harm. But again, they have injections, sub-Q injections, the parents can give daily of these factors. So that a lot of them, even if when they do bleed, doesn't mean they're not going to bleed longer too, but it's not going to be like it used to be. I mean, it used to be, you know, really bad if they had, you know, and you're not going to see so much of that as severe. They might still need a blood transfusion, but it's not going to be as severe as was. So we're better able to manage.
How often do they need to get replacement of missing clotting factors?
Every day they get sub-Q injections, classic type. I focus in on the one type because there's different ways and different management. So the classic, which is what your book talked about too, hemophilia type 8 classic fact, that one they can replace the factor, so daily sub-Q. But again, that doesn't make it perfect, because it's only synthetic, it's never gonna be, so they still can have a lot of bleeding, but not as it would have been years ago, let's say. It's more manageable. Iron deficiency anemia, rare before 4 to 6 months of age. Again, Ina mentioned before, because they have the maternal hemoglobin kind of protecting them. After that point, infants do need iron in their diets. Now, most formulas have iron. Infant vitamins have iron in them, are iron fortified. So even if they're breastfeeding, there is multivitamins that they can be given orally in a dropper that can help with the iron. So that being said, we still get children and infants with iron deficiency anemia. And even young girls, when they first start menstruating, can be at risk for iron deficiency anemia. Young children can decrease their growth rate, their development, they can have some paleness, activity exercise intolerance, dyspnea, and low hemoglobin levels, what they look at. So obviously, again, for this, you're going to give iron. They do say iron in a dropper. There's liquid versions of it, but obviously in the dropper is the best thing. You want to make sure it doesn't touch the teeth, because it can stain the teeth. So that's the big thing with that. Yeah, like they say, a straw or a dropper. Most times a dropper, because they're young infants. Brushing the teeth afterwards even. And the best thing, this is key too, you don't want to do it right before breakfast, right after breakfast. A lot of parents in the morning, they wake up, they give it to their children, and then they feed them. It's best absorbed in an acidic environment. So actually midday between meals is the best time to give it. This is something that people always kind of forget about or forget to mention to parents. And you don't want the children, some of these vitamins, like the Flintstone vitamins, and the Princess vitamins they have now, and Winnie the Pooh, they look like candy, these gummy things, especially when they're iron fortified, but they actually can be poisonous, and they look like gummy bears. That's what they really are, basically, these gummies that the older children, so they are something that should not be kept in the children's reach. They should be kept away. They obviously have the child-proof lids, but that doesn't mean children can't figure that out, some of the older ones, and then they could eat a whole of it, yeah. So it can be poisons. It can actually give them toxicity of these levels, especially iron that's in a lot of them that's fortified. So again, you want to keep these kind of things away from children, and then monitoring their CBC. Thalassemia. This is something that's just nice to know. I'm not going to go into this one, but just so you know, there's something called Cooley's anemia or thalassemia, which is seen in Mediterranean descent. Okay, European Mediterranean descent, and that is a type of anemia in which everything is missing. So you have a decreased platelets, almost like a very lowered, like missing platelets, you're missing red blood cells, you're missing white blood cells. So they need whole blood transfusions basically every week is what they give them. Otherwise they won't do it. And they usually do not do well if they have the severe version of this. It is autosomal recessive. Just a nice to know kind of thing.
What about like the clotting factor?
Clotting factors, no, they're missing the blood cells, exactly. It has to do with the blood cells, not so much the clotting and things like that. Aplastic anemia, what you want to know about this is a complication of a lot of times. Most children are not born with aplastic anemia, and if they are, they don't do well. But what aplastic anemia, who gets aplastic anemia, first of all? Well, people that, yes, that's right, Stephanie. People who have chemotherapy, who are under chemotherapy. Okay, so somebody's under chemotherapy, when they get to that nadir point, which is somewhere like 10 days after they had their chemotherapy infusion, they go through this, they can go into an aplastic anemia, which is basically that the bone marrow stops producing the cells, red blood cells, white blood cells, platelets are all low, extremely low, which puts them at risk for infection, bleeding, and severe anemia, and lack of oxygen. So usually they need blood transfusions. The good thing is people who are on chemotherapeutic agents nowadays, there's a lot they can give them. They can actually give them things that will stimulate white blood cell production right after usually they go for their chemotherapy infusion, and like a day or two later they actually give them some injections that will help stimulate white blood cell production prior to reaching that nadir point to keep them from getting as infected or at risk for infection. But they still have to be careful, and obviously aplastic anemia is still something that can happen for somebody, again, chemotherapeutic. And since we're going to talk about leukemia in a little bit, that's why I mentioned it here too.
So, Professor, question.
Yes,
So aplastic anemia,
you can put it off.
basically apply